I would like to introduce myself. I am Rubia. My colleagues and I are here to present on behalf of Aboriginal and Torres Strait Islander peoples. We are here to present the 5 main factors that are affecting the Indigenous people of Australia. Firstly, in keeping with the spirit of reconciliation, I acknowledge the traditional owners of the lands we hear QUT stands for. My name is Rubia, and I'm going to discuss the barriers that prevent the current mainstream health system from meeting the holistic needs of Aboriginal and Torres Strait Islander peoples. Secondly, Niree will be talking about the strengths of Aboriginal community-controlled health services in response to the holistic needs of Indigenous people. Thirdly, Ben will discuss how Indigenous people who identify as lesbian, gay, bisexual, transgender, intersex, queer, brother boys, or sister girls suffer from multiple layers of disadvantage due to intersectionality. Next, Pauline will talk about the common health system factors that contribute to Indigenous rates of DAMA, or discharge against medical advice. Lastly, the political imperative of well-being will be discussed by Lucille. There are barriers in achieving the holistic needs of Indigenous people. There are still high rates of unemployment, limited access to health and education. These disadvantages are shaped by their broader socio-economic conditions, where it all lie in the circumstances in which people are born, grow, live, and work. For example, one barrier is communication. Not all Indigenous people speak English, or there is ineffective communication practices with the healthcare workers, where the Indigenous individuals feel rejected from understanding their health issues. Next is social exclusion. Many Aboriginals still live in remote areas where advanced health care services and facilities are far-reached. As Professor Michael Marmot said, Indigenous communities living in remote areas is a lifestyle choice. Lastly, early childhood's optimal development and access to education are prerequisite to employment, which needs physically and mentally healthy. However, substance abuse and alcohol consumption are high with Indigenous people. Therefore, these are the challenges that the mainstream health system are facing in making a possible progress in achieving the holistic needs of Indigenous communities.
Aboriginal community-controlled services first started in 1971 in Redfern out of a growing need to encourage our Aboriginal and Torres Strait Islander people to seek health care. Due to a lack of cultural understanding from mainstream health providers and a fear of the clinical unknown, Indigenous people were found to be dislocated from receiving treatment for a myriad of concerns. It has proven that social determinants such as housing, socioeconomic situation, and education heavily impact on a person's health. The fundamental concept behind each ACCHS, whether metropolitan, rural or remote, is the establishment of a primary health care facility that is both built and run by the local Aboriginal people to deliver holistic, comprehensive and culturally appropriate health care to the community which controls it. Each ACCHS is unique and flexible in the programs it runs in the response to the needs of the region. Indigenous community workers are employed to liaise with allied health staff, community and family members, identifying special needs and developing courses that facilitate improved well-being. Education becomes a communal priority and advocacy provides a voice for their needs. Indigenous liaison officers work within the hospital setting, providing them with a connection to home and family, organising accommodation and transportation, and explaining the procedures they will undergo whilst in hospital. Funding is provided by federal and state governments, hence it is pivotal that they develop synergies to increase cultural safety, subsequently reducing an overlapping of services.
LGBTQI Indigenous people are more likely to have diverse mental and physical health concerns. Andrew Farrell is a queer Aboriginal drag queen and shares that being queer and Aboriginal in a dominantly white heteropatriarchal space generates a unique instability and vulnerability. LGBTQI people have the highest rates of self-harm and suicide in Australia, 14 times higher than that of their heterosexual peers. Due to the gaps in the Australian standards for collecting sex and gender information, LGBTQI Indigenous people are widely unrepresented. Therefore, it is difficult to accurately calculate the health statistics for this demographic. Lack of statistical representation has led to a deficit of resources devoted to the health and well-being of this intersectional community. Unique outreach services are starting to appear. However, due to the remoteness of some communities and accessibility and awareness issues arise, the Queensland AIDS Council runs the Two Spirits program. However, due to the funding constraints, can only focus on gay men and sister girls. In 2013, a national group, Black Rainbow, was established to provide the highest level of social, cultural and mental health support and agency to Indigenous people who identify as LGBTQI. However, Black Rainbow is still in its infancy, relying on private funding to leverage policy and expand awareness. Further development into and growth of LGBTQI Indigenous services are required to increase the well-being of this demographic.
Discharge against medical advice, or DAMA, is defined as the circumstance in which a patient leaves the hospital before his healthcare provider suggests release. It is related with unfavorable results and is viewed as a pointer of the responsiveness of the healthcare to the requirements of the Indigenous individuals of Australia. It is correlated with elevated morbidity, mortality, healthcare costs, and patients' readmissions. A recent national report indicated that discharge against medical advice was more prevalent in the remote areas, and it noted that the key variables observed to be related with DAMA were inability to understand the reason for admission, as doctors were unable to confer even basic medical concepts to them, miscommunication and alienation, as medical staff also lacked appropriate cultural training, family and social obligations, inability to trust doctors or the hospital due to historical reasons, language barriers, that is, use of English as a second language, the impersonal nature of Western medicine, the feeling of being unwelcomed and misunderstood, association of large hospitals with death, terminally ill patients referred to die at home close to their loved ones. Cultural competency of staff in the healthcare system significantly influences all aspects of Aboriginal and Torres Strait Islander patient care. Willingness to access service, quality of care, and healthcare outcomes. Therefore, an accurate understanding of patient experiences in hospital and satisfaction with the care is key to shaping an effective health policy. Due to inequality in healthcare for the Indigenous people is a critical national policy issue. As a result, Closing the Gap program was established. Its goal is to work together to achieve equality in the healthcare for the Indigenous and non-Indigenous people.
The nursing profession has traditionally been central in patient advocacy. Owing to the problems just illustrated, it is clear more needs to be done to prepare nurses to advocate effectively for Aboriginal and Torres Strait Islanders. The institutional racism that is apparent in the Australian healthcare system prohibits nurses adequately advocating for Indigenous people. Indigenous people need to be made safe whenever they are accessing healthcare. All nurses need to be trained in Indigenous culture and history. The National Aboriginal and Torres Strait Islander Women's Health Strategy recommends providing all nursing staff with cultural competency training. This would improve communication and understanding of how Indigenous people relate and give insight into their worldviews and cultural needs, improving health outcomes for Indigenous people. According to the ANMC, the Australian Nursing and Midwifery Council, an audit in 2005 showed only 22 of 35 schools of nursing offered an independent unit on Indigenous Australian health in their undergraduate courses. Therefore, not all nurses are equipped with Indigenous cultural safety competency. Training for all nurses will improve communication with the patient, family, and Aboriginal liaison health officers and result in better compliance with medical treatments and reduce walkout rates. The shortage of Aboriginal liaison health officers means it is more essential that nurses can better advocate appropriately for Indigenous Australians. Further investment into cultural safety competency training will enable healthcare staff to provide appropriate care to Indigenous people. Therefore, nursing staff will be able to effectively advocate for Indigenous healthcare needs. I would like to thank the Board of Directors and the CEO for your time.